Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Well, we have 5 or 6 great questions today, so let's just get started. Our first question for each day, Dr. Mingle, comes from Corinne. And Corinne asks, we have a group of close to 40 MDs, and our composite MIPS score was 80.2 in 2022. It was enough to earn a small positive adjustment, but we are really concerned about the proposal to increase the performance threshold to 82 for 2024. Do you have any advice for us?
82 is going to be hard. I think a lot of organizations are going to shift their strategy from earning a positive adjustment to minimizing their negative adjustment. If you're determined to get above 82, first thing, you have to earn all of your gimme points. There's no reason you can't earn all of the available 15 points for improvement activities. Make sure early in the year that you have that covered. It may take a little more investment. I can say it will take a little more investment, but earning all 25 points available for promoting interoperability is also a priority. Biggest challenge, too, is likely to be the public health registry measure. In that measure, you are dependent on your vendor being willing to connect and a local public entity that has invested in the connectivity infrastructure and then fitting the project into your budget. And the other interoperability measures, that is physician to physician each way in the referral and physician to patient, are not trivial. With improvement activities and promoting interoperability in the bag, that's 40 points of your required 82. You still need 42 of the possible 60 points in cost and quality to avoid a negative adjustment, 30 points being available for each. If you have that perfect score in improvement activities and promoting interoperability, you'll need to earn 70% of the available points in cost and quality to avoid a negative adjustment. Earning the 30 points in quality is achievable, though hard. The score you need for each measure is published in advance based on national scores from 2 years prior to the current performance year. It will take a coordinated effort of your whole practice to achieve optimum results for each measure. The cost performance category may be your biggest challenge. Of the 4 performance categories, promoting interoperability, improvement activities, quality, and cost is the only category truly scored on a percentile rank, and with a comparison made to your peers in the performance year. It is the only category to make use of the entire range of possible scores from the 1st to the 100th percentile, or from 0 to 30 points. Of the 30 available points in cost, half of practices will be below 15 points and half will be above, roughly speaking. If you're at the average of 15 points, you will need 27 of 30 quality points to reach the performance threshold. Now, cost is hard to follow in the short term. Quick turnaround on measures is hard to come by. And cost is hard to change. It's mired in local habits, traditions, expectations of patients, providers, and payers. Your best guidance to your cost performance is previous scores. Although there will be some random variation from year to year, without concerted effort, it won't vary much. It makes great sense to engage a reputable registry like Mingle Health. Get involved early. Submit quality data regularly, at least quarterly, to monitor your quality scoring and take action early enough to improve your scores with enough time ahead of you to improve your final annual MIPS composite score. A good registry like Mingle Health will not only help you build a competitive quality score, but we can provide guidance, advice, and submissions where indicated for the promoting interoperability category, improvement activities category, and, well, of course, we don't submit, but we can provide some guidance for improving your cost category. We also monitor the rules for you to make sure you are aware in a timely fashion of changes that are important to you. Thanks, Corinne.
Yeah, thank you, Corinne, for the great question. Our next question for you today, Dr. Mingle, comes from Kennedy. And Kennedy asks, we have some practices that will be joining our organization mid-year. We are trying to understand what this means to us for MIPS reporting for the year they join. The practices are small compared to our whole group and will represent less than 70% of our total patient volume. So even if we don't get all of the data for the year they join us, we should be confident that they are not pulling us below the data completeness requirement. But we are confused by the apparent contradiction in Medicare's statement that we must account for 100% of our eligible patients. Can you explain this?
Great question, Kennedy. Most of you are aware that Medicare's data completeness requirement is 70% for 2023, goes up to 75% for 2024 and 2025, and proposed to go up to 80% for the 2026 performance year. But seeming to contradict the leniency of that requirement is Medicare's assertion that you have to account for 100% of your eligible patients. This is difficult for a lot of people. I'll try to help you make some sense of that. This apparent contradiction is resolved with firm division in your mind of numerator to denominator. The denominator is the count of the patient's visits or episodes of care that are eligible for a measure. Because the denominator can be a count of different things, Medicare calls the things that are counted eligible instances. A denominator is a count of eligible instances that could be patients, visits, or events, or something else, I suppose. These instances represent opportunities to provide care. Now, it's easier to count the instances or opportunities than it is to identify with clear and unambiguous data the care provided. Determining the denominator or the eligible instances is the first step in any quality reporting effort. Now, Medicare requires you to know what this total number is. It's only by having an accurate denominator count you can know when you or Medicare can know that you have fallen below the data completeness threshold. Denominator data primarily comes from claims records. The great thing about claims data, it is nearly universally available. It's been around long enough that it's a mature and stable data set with nearly universally accepted standards. Every practice generates insurance claims. Claims are relatively simple and standardized. Electronic claims were all designed to emulate Medicare's paper HCFA 1500 forms. They all include universally recognized data standards of ICD-10 diagnosis codes and CPT service codes. A healthcare claim nicely defines the existence of a patient-doctor relationship. In the claims are identified this doctor on this date saw this patient of this gender and this date of birth providing these services for these diagnoses. That data set is the foundation of or the denominator for every measure. Getting that data is not a trivial exercise, but it is generally achievable in nearly every practice of any size. There are at least 3 different ways to get the data, and part of our task at Mingle Health is to help you find the best way, given the unique strengths and weaknesses of your practice, to get the data from each of your practices. It should also help you to know that claims data from your practice management system is adequately standardized so that there are rarely any barriers to combining that data from multiple practices. Multiple practice management systems in one practice in the same year, or any other mixing or matching you need to do. Now that you know that the denominator is a count of eligible instances, the gold standard for the count comes from claims data, and Medicare wants you to be 100% accurate on the count. Let's talk about numerator data and data completeness. Numerator data is primarily clinical data. It answers the specific question, what happened to the patients, or in the visits, or in the episodes that represent our denominator? Did they get what they want them to get? Did they avoid complications? Numerator data is not as mature, standardized, or as available as claims data. The 3 big problems with clinical data are Too much of our clinical data is in natural language form, not in structured or discrete elements that are accessible to a reporting infrastructure. Numerator specifications are not always optimized for a structured data set. We don't have solid standards for expressing commonly required quality measurement concepts. The project and process changes dramatically when you change EHR, even if you're changing to a new instance or version of the same EHR. Medicare gives you a little more leeway with the numerator. Enter the data completeness criteria. So in review, in reference to the requirement to report 100% of the patients, Medicare is referring to the denominator, which counts the patient's visit or episodes of care that a standard of care applies to. With a 100% requirement, they are saying that you must know who your patients are, even if you don't know what you did for them. In reference to the 70, 75, or 80% data completeness requirement, Medicare is referring to the numerator, which is the care provided found in the clinical data in the EHR or your paper chart if you're still on paper. Thanks, Kennedy.
Yeah, thank you, Kennedy. And our next question today is from Greg, and it's a great follow-up to Kennedy's question. So Greg asks, are we going to be penalized if we make an error in counting the eligible instances?
Greg, again, as I discussed earlier, Medicare requires that you know 100% of your patients for any measure. But don't sweat the details too much. You need to make a credible effort, but there's always error in any measurement. Medicare knows that as well as anybody else and accounts for it. You don't need to worry if your error rate is in the low single digits. Medicare seems to tolerate about a 3% error rate before they take corrective action. Thanks, Greg.
Our next question for you today, Dr. Mingle, is from Jean. So Jean asks, you have said that data completeness criteria applies to numerators and that Medicare wants us to report 100% of our denominators and that the gold standard for denominator data is claims data. But there are many measures that have clinical data that define the denominator. Can you explain this?
Thanks, Jean. I was hoping to get that question. It is a source of some confusion. In the early days of quality reporting, measure authors limited denominator specifications to claims accessible data. That proved limiting and swelled the denominators for many measures to massive levels. Now we see a mix. At Mingle, we take a stepwise approach to calculating denominators. Every time we import claims data, we run the data set against claims accessible denominator specifications, producing what we call denominator candidates. Your true denominator patients will be in that group, but it swells it to include patients that for which will be excluded by clinical factors that we don't yet have. We can't get that final denominator count until the clinical data is added in. But when you're calculating reporting rates and answering the question, am I meeting data completeness requirements, we find that calculating from the denominator candidates yields a credible calculation. If you examine the logic, true eligible instances can never be higher than the denominator candidates. All true eligible instances are contained within the denominator candidates. The factors that make them different numbers are reasonably expected to be similar in occurrence rate from practice to practice. And despite not being able to find the actual final denominator count, counts of denominator candidates reflect the actual distribution of eligible instances across your many practices. And it's a source of credible calculation of data completeness. The percentage in your denominator candidates should be very close to the percentage in your true denominator counts.
Thank you, Jean, for the great question. Our next question for you today, Dr. Mingle, is from Georgina. And Georgina asks, Medicare requires that the quality reports for our Medicare Shared Savings Plan ACO be deduplicated for patients amongst our many practices. Don't we have to have an Enterprise Master Patient Index, an EMPI, to accomplish the requirements of the APM performance pathway, that is the APP?
Great question, Georgina. The EMPI, that is the Enterprise Master Patient Index, is a great tool and will give you a great deal more confidence in your patient identification. The level of accuracy and confidence the EMPI provides is a tremendous advantage to guide the clinical care in a diverse community healthcare system. But the EMPI is more discernment than you need for value-based care quality reporting. Medicare measures and compares your quality with your peers, calculating the performance rate out to 4 decimal places, or 2 decimal places if you're considering the percentage calculation. We find that combining simple, always present data from multiple claims data sets, we achieve confidence in identification out to the limit on which you get reported and scored. If you have an EMPI, so much the better. We'd love to have that data from you. Providing us with your EMPI identifier with all of your data definitely makes deduplication easier. But we can accomplish what you need for your quality reporting just with your claims data with their typical data set. Thanks, Georgina, for the great question.
And our final question today comes from Arlene. And Arlene asks, Medicare has proposed a Medicare CQM to make compliance with the APP, that is the APM performance pathway, easier over the next few years. So, Dr. Mingle, do you think we should use Medicare CQMs for our ACO if this proposal is finalized?
Great question, Arlene. I think that Medicare CQMs will be a valid and useful tool, but it will not offer a big advantage over MIPS CQMs. Medicare proposes Medicare CQMs as an alternate quality data collection type for Medicare Shared Savings Plan, that's the MSSP, ACOs to meet the requirement of the APM performance pathway, that's the APP. The proposal is that Medicare CQMs will use the same measures with the same specifications as MIPS CQMs, but they'll restrict the denominator patients to Medicare Part B beneficiaries, setting aside the all-patient, all-payer inclusiveness of MIPS CQMs. To support this and provide a tool to help ACOs aggregate and deduplicate patients across their practices, Medicare proposes to provide a list of performance year Medicare Part B patients of the ACO to the ACO early in January of the submission season. Now, Medicare patients is helpful, but it's not an enormous help to you. It can't be your sole source of your patient list because it will only include patients through the third quarter of the performance year. And the process of matching those patients on the list to the patients in each of your claims data sets or even your EHR data sets is still a similar process with or without that data set. If you're working with us and we have claims data from each of your practices, we have enough to deduplicate your patients. And by filtering on Medicare Part B claims, we can easily toggle between Medicare CQM and MIPS CQM submissions, telling you in advance how you may perform on each. As we envision the process of using Medicare's patient list to assist the process, we don't see a substantial additional effort that gives you a distinct advantage. But still, there are advantages to the Medicare CQM. If you have to manually abstract some of your charts to meet your data completeness requirements, or you need to uncover electronically inaccessible positive performance data, the Medicare CQM route gives you a far smaller chart set or data set to abstract than does the corresponding MIPS CQM. It's also credible to think that there are enough differences in the Medicare Part B patient and care dynamics that there might be a better performance score found in your Medicare Part B limited patient population as there is in your general all patient, all payer population. Although there's also a possibility the reverse is true, and that your general population may be performing better in some measures against your Medicare Part B patients. Thanks, Arlene.
Yeah, thank you to Arlene and everyone else for the excellent questions today. And please remember, you can always leave a question for Dr. Mingle in a comment on LinkedIn or YouTube, or send it directly to us at hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks for all the great questions. I want to be helpful, and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.